All right, good afternoon, everybody. We will get things started. First and foremost, want to thank our colleagues at the Department of Safety for graciously hosting this afternoon's conversation. They've got some really nice digs over here. It's good to see how the other half lives, but we appreciate their willingness to do this for us. Want to thank, too, Megan Morris for coming up from PCG. Appreciate you traveling up here to talk about this presentation. Great to see a wide diversity of folks, not only here in the room, but I know there are a number of people joining us online. And just so everybody is aware, this is being recorded, so if you miss any part of the presentation today, or if you want to rewind the tape and go back, clarify your hearing on anything, you'll have the ability to do that. We'll try to turn that recording around as quickly as we possibly can. I want to take just another second to introduce some members of the insurance department who are here for today's presentation. I'll lead things off with Michelle Heaton, who leads our Life and Health Division. Next to her is Dr. Jason Azes, who leads our Data Analytics Unit. Alex Feldave, I joke, he's like the Swiss Army knife of the department. I'm not sure exactly what his title is, but utility man seems to be practically speaking what he does, so we appreciate that. And then as well, Jen Smith, our legislative director in the back. For those of you who have spent any time in the legislature, Jen is familiar to you. And then, of course, A.J. Kierstead, who is handling all of the tech in the room today. Appreciate all of their hard work. I want to take just a second to hopefully set a bit of a constructive tone for the conversation this afternoon and redirect everybody's focus and attention to the fact that all of us are here and all of us have been involved with this issue. Some of you I know for a very, very long time because we are trying to solve a difficult challenge. And it is a difficult challenge that affects the public in a diversity of ways. We obviously have a vested interest in ensuring that our EMS providers are getting the support and have the financial stability that they need to provide the critical services to our citizens. We obviously want to ensure that our citizens have access to the important services that EMS provides. And then from a consumer protection standpoint at the department level, we want to try to do what we can to move on from the necessity of balanced billing, because we hear from so many of our consumers how challenging and difficult financially it is for them and how confusing and frustrating it is for them to have in their minds that they have insurance coverage and then to receive this bill later that they don't understand, didn't appreciate was coming, and again, for a lot of them is a financial challenge. My philosophy as commissioner has been and will always continue to be that I'm not going to identify problems or challenges without also bringing forward a potential solution for consideration to address that challenge. And so the same philosophy is exactly what I've tried to apply to this challenge. So that is how we have come to the place that we're at. In crafting the solution for consideration, we obviously want to bring as much information and data to the table as possible. And in so doing, we want to try to do so in as transparent a manner as possible. And again, that's the core of what today's presentation is all about, so that as you look at the ideas that we have brought to the table to try to address this challenge, you understand exactly the analysis that was done that we're relying upon to underpin that solution, allow you to be able to answer questions, and hopefully get some important information back. I appreciate the fact that as we've discussed this issue, not only this particular legislative session, but for many years prior to, that the parties have had different solutions and that there's been disagreement about the best way to go about solving this problem. And as far as I'm concerned, that's perfectly fine. I think a good, healthy debate taking into account various different viewpoints is very, very helpful. At the end of the day, what we do about this is in the hands of the legislature, those who are elected by the people of this state to represent them and ultimately to determine the best way and the best approach to solving these difficult public policy issues. One of the things that I think has been a bit regrettable is that as we've discussed some of those disagreements or some of those differences of opinion or view, that it has from time to time gotten a bit contentious. And I want to be clear, I'm not here to pick one side over the other, over the other, over the other. I'm simply trying to bring forward a solution to a problem that I believe is in the best interest overall of the people of our state. But I do want you to understand how we got to where we did. Again, what is driving our perspective on this issue. And again, allow you the opportunity to not only better understand it, but to ask any questions that you all might have. And that in the end, again, it will be for our legislative friends to ultimately determine the best way that they would like to go about this. But I think for us, trying to bring as much data and information to the table as possible, I hope, it is my goal, and I think it's borne out with some success over the years, helps the legislature find the right balance and to find the right approach. Today is about getting information and asking questions. It's not to debate one proposal over the other. Again, I think that's a discussion to be played out before our friends in the legislature, because it's their decision to make. So staying focused on today's analysis, I think, is where we should be. It's where I would encourage you all to be. But with that all being said, Michelle, are you coming up next, or are we going right to Megan? Going right to Megan. All right. Megan Morris, everyone, from PCG.
So I was planning on starting by asking folks to identify who's here representing licensed EMS units and who's here representing the legislature. But I think looking at around the room, it's pretty clear. And I just want to start by saying that I really, really appreciate you all coming out here. I know that you all wear many hats, and I appreciate you taking the time to come in and learn more about the work that we did. I hope I'm able to answer a lot of your questions and provide some clarity on the work that we did. And we do have a PowerPoint presentation. My goal here is really just to tell the story of our work. So starting in August when we began the work through when the report was finalized and eventually published in December and January. And really just kind of walk you through the decision making and the steps that were taken to get all the way to the end of the report. But before I do that, I'll introduce myself. I'm Megan Morris. I'm an associate manager with Public Consulting Group, and we were engaged to develop this report. My role is focused on provider payment modeling, which is rate setting, cost reporting, really anything to do with healthcare provider cost. And I've also been working with ambulance service providers in particular, dating back to 2016. I've worked on a handful of states that have GEMT programs that participate in Medicaid cost reporting, so I'm very familiar with the EMS landscape. And I was supported by an absolute ton of folks. We had a team that included some project management experts. We had some experts on the Medicare ground ambulance data collection tool. And we also had partners at Lewis and Ellis, which is an actuarial firm that was really focused on the impact assessment piece of the work, so quantifying the impact on insurance premiums of adopting our rates. All right, so just jumping right in, I think the first thing we want to do is give a little bit of an overview of the project. And it was really began with some legislation. SB 407 directed that an independent cost study of the New Hampshire ground ambulance cost be conducted. We'll provide a little bit more on the next slide of some of the parameters behind that cost study, but the cost study was really sort of led by this legislation. I think we worked very closely throughout with the NHHP team, the insurance department, and the Department of Safety. You may hear me refer to them as the core project team, and that's how they're referenced throughout the report. Those folks put an absolute ton of work into this initiative. We met weekly. We spent a lot of time reviewing data, discussing every recommendation to make sure that that New Hampshire specific lens was appropriately considered. And it was definitely a very collaborative effort that allowed us to complete the rate study during this 5-month period. And the underlying goal was to develop a rate schedule specifically to support fully insured commercial payers that are reimbursing non-participating ground ambulance providers, so out-of-network providers. All right, so now I'll get in a little bit into the parameters of SB 407. So again, this was the enabling legislation that started our work. And the goal of SB 407 was to create a cost study, but it had some specific parameters about how we evaluated cost. So it was costs attributable to the provision of covered services, and a couple of underlying assumptions. One is that all payers are paying the rates that we recommend, so it's not just this limited pool of out-of-network commercial. And the second is that the rate of revenue received for ground ambulance services in the state through public funds remains constant. This is something that we referenced in our report as taxpayer dollars earmarked for EMS. Another parameter is that costs have to include the cost of pre-hospital care and the cost of sustaining a reasonable operating margin that's necessary to provide these services and to be able to meet future demand. So we looked at that. We also talked quite a bit about readiness. So one thing that this report really recognized is that there's a lot more cost incurred to render ambulance services than the cost that's incurred during, let's say, the 45 minutes or the hour duration of the response. Folks have to be on hand 24/7, and you don't necessarily know when those emergency calls are going to come in. So that readiness piece was really key to how we evaluated cost. The last one is cost estimates shall assume that services shall be provided in a reasonably cost-effective manner. So again, really the underlying goal of the core project team was to help us make sure that we remained in alignment with the intent of the legislation. All right, so now I'm really going to get into the part that I think of as the fun part, which is the data. And I'm sorry in advance if I start to lose you, but we're going to get a little in the weeds here, and I really look forward to your questions. The first thing is data sources and collection. So where did we get the data from? And the answer there is really the licensed EMS units were the primary source of data. Almost all components of our rate model were utilizing the data that we collected directly from licensed EMS units. And one thing that I want to say up front is that we got a really fantastic response rate from licensed EMS units in the state. I don't want to say it's the best that I've ever worked on, but it actually is. This is by far, if we look at the number of participating providers as a percentage of the universe of providers that are operating in the state, you all were above and beyond and were incredibly responsive, not only to the surveys that we sent out, but also to any follow-up questions that came out of the surveys. So we definitely want to reiterate the appreciation for the role that licensed EMS units played in getting us the data to complete this work. So initially, when we started talking about data collection, we sort of had two goals. We want as much data as we can possibly get, and then we don't want to ask too much of responding providers. And so the solution that we came up with was to lean very heavily on the recently completed Medicare ground ambulance data collection survey. And the timing worked out very well. So the ground ambulance data collection survey was a Medicare initiative that required all licensed EMS units operating in the country to participate in what was originally intended to be 4 rounds of reporting, but was condensed due to the COVID-19 pandemic into really just 2 reporting years. So there was the year 1 and 2 selected providers that would have submitted data based on 2022. And they had the option of either using calendar year 2022 or their own fiscal year that began in 2022. So if you use, let's say, the federal fiscal year of October through September, you could have submitted your year 1 or 2 GAD survey based on that October through September of 2023 time period. And this is kind of an important nuance because I want to make the point that, so those year 3 and 4 providers that were based on 2023, that was just wrapping up as we were starting our data collection. So we recognized up front that there may be some licensed EMS units in the state that haven't yet submitted their GADs. There's also an option for providers, instead of submitting their GADs, they can take a penalty from Medicare, so a 10% reduction in Medicare payments. So we understood going in that using the GADS data alone was not going to allow for maximum participation in the state. There may be a handful of providers in the state that were still completing their GADS survey, and there may be others who just did not participate. So the path that we went down was first trying to answer the question of how many did participate and how many didn't. And so we started out with what we referred to as the profile survey. We use this to collect some general information about licensed EMS units that responded, things like, are you public, private, nonprofit? Are you fire-based? Are you EMS only? Are you affiliated with a hospital? And then we also asked, did you complete a GAD survey? And based on those initial profile survey responses, we went down two distinct data collection paths. One was for those that had completed the GAD survey. We followed up and said, would you share it with us? And for those that had not yet completed the GAD survey, we had a abridged version of the GAD survey which went out. So we tried to create as much alignment between the two data sources as we can, but the GAD survey was a really intensive data collection process that required quite a bit of information that we didn't ultimately incorporate into our work. So at the end of all of that, we were able to collect a total of 108 responses through both the GADS and the non-GADS data collection, which was absolutely fantastic. The other data source that we used is what we refer to as the CHIS, which is the all-payer claims database in the state. That was particularly useful for our Lewis and Ellis partners who did the actuarial analysis of the impact on insurance premiums. They were able to really understand current billing activities based on that all-payer claims data that was available. So now at this point, we've gone out to the licensed EMS units in the state. We've provided two paths to provide data, and we've collected that data. So now we're sort of moving into the second bullet here, which is assessing the representativeness. So one thing we knew we didn't want is to collect data exclusively from large providers or exclusively from licensed EMS units operating in one particular area of the state. So we looked at that across a few different parameters, type, size, classification, and geographical region to make sure that the data we collected aligned closely with our understanding of the overall universe of licensed EMS units that were operating in the state as of the fall of 2024 when we were really doing this work. And I'll just nod to the Department of Safety that was really instrumental in helping us form that understanding of that universe and making sure that we were able to make a clear comparison between the data that we had and the overall potential universe of providers that are operating here. So when we did that, we found a very close alignment between the makeup of licensed EMS units in the state and the makeup of licensed EMS units that provided data to us through the convenience sampling survey that we executed. So I think that brings us to finalizing the analytical sample. So at this point, we've collected 108 responses, but we still need to review them. So the first thing that we did was look at them and say, number one, is the data complete? And number two, does the data make sense? And so there were some instances where the data was significantly incomplete. And when I say that, what I mean is there are really two key areas of focus of this study. What cost do you incur in a typical year to render EMS services? And then how many services are you rendering in that year? So that sort of ratio of cost to transports was sort of fundamental to the work that we did. So for those where either cost data was missing altogether or transport data was missing altogether, we ended up excluding them for missing data. But for those where there might be something minor, like we don't know what your GADS data collection window was, and we want to make sure we're using an appropriate inflation rate. We did go back and forth with licensed EMS units. And we also raised some questions where when we looked at the information that we got, it didn't seem totally reasonable. So one example is through the GADS data collection, we get an understanding of the number of positions by professional level, so let's say EMTs, and then the cost incurred. So we're able to do some math to determine, on average, what is the cost to employ an EMT. And so we looked at Bureau of Labor statistics and other metrics to determine what might be an expected range. And for those that were really far outside of that expected range, we did some follow-up there as well. And again, I'll reiterate, the responsiveness and participation was absolutely fantastic, and we really appreciate all the effort that went into providing that data and providing clarification where it was needed. All right, so we started with 108. At this point, we excluded 23 of those responses for missing data. So again, those are ones where there's a significant key chunk of data that's missing that would prevent us from being able to do our analysis. And the next thing we did was we looked at the distribution of the data, and we found that the distribution was skewed. And so we ended up using an outlier exclusion methodology called 1.5 times IQR. It's the interquartile range, which is the distance between the first quartile, so sort of the lowest 25% of providers, and then that third quartile, which is the barrier between the upper middle quartile and then the top quartile of providers, so sort of that 75% mark. So when we looked at the average cost per transport incurred, we took the range between the 25th percentile and the 75th percentile, or the interquartile range. We multiplied that by 1.5, and then we added that to the third quartile and subtracted it from the first quartile. And so for those that fell outside of those boundaries, we excluded them as outliers. And that ended up being another 12 exclusions, which left us with a final sample of 73. All right, so at this point, we've got our data, we've reviewed our data, we've limited it to our included sample of 73 licensed EMS units, and now we need to really figure out, are there any adjustments that we need to make to this data to make sure that we're appropriately considering various factors? And one really key one was inflation. So because we use the GADS data as the basis of the bulk of our data collection, we knew that we were getting data that went back to a bunch of different time periods. So again, 2022 and 2023 were the two GADS years, but licensed EMS units had the option of using their own fiscal year instead of the calendar year. So we had a wide array of different time frames that we were looking at when we were looking at cost data. So we used the consumer price index to take the data that we received and apply individual inflation adjustments so that each of those participating licensed EMS units in that included sample were inflated up to a uniform period of time. The next thing we did was we identified that there were a handful of out-of-state providers that are providing services in New Hampshire. And so we had a concern that their data that they shared with us may represent services provided here as well as in other places. So they may have a significant impact based on responses that they did outside of the state of New Hampshire. So for those licensed EMS units that were identified as based out of state, we did some follow-up and we coordinated again with the core project team, and we were able to prorate their volume of transports and their total reported cost to just the portion that's associated with the work they did here. The next thing we did was we recognized that a lot of the participating licensed EMS units use volunteers. And through the GADS or the non-GADS survey, we did ask some questions and there was some information provided about the prevalence of volunteers, and particularly unpaid volunteers that are supporting these services. So in those instances where a licensed EMS unit is using volunteer staff, we inflated up their cost to assume that they were paying their volunteers at a level that's comparable with the average for the professional level of a volunteer. So if you had a volunteer EMT, we would look at the average compensation cost for an EMT and apply that to that one volunteer position and incorporate that into your overarching cost. And the last thing that we did was integrate those taxpayer dollars earmarked for EMS. So again, going back to the enabling legislation, there was a parameter regarding considering a constant level of taxpayer dollars earmarked for EMS. So those were also integrated into the cost sample as a reduction. So we were able to look at the net cost of providing these services for a year after inflation, after out-of-state adjustments, after volunteer cost, and then after reducing the impact of taxpayer dollars earmarked for EMS. All right, now we get into the really fun part. So we have the data. We know at this point how much it costs these 73 providers based on today's dollars to render these transports within the state of New Hampshire. And we also have quite a bit of data on the transports themselves. So we know how many transports were provided. We know of those transports, what category of service was rendered. Was it a basic life support or advanced life support or specialty care transport? And through the GAD survey, we also know how many instances there were where medical care was rendered on the scene and no transport was provided. So that's all information we sort of had going into our final calculation. And our charge was to set reimbursement rates that were specific for billing purposes. So we know when you bill 1 unit of basic life support, you don't expect reimbursement at the same level as 1 unit of advanced life support because there's a higher cost associated with advanced life support. Those services tend to take longer. You need more specialized equipment. You might need a different credential level of professional to offer that advanced life support service. And so we wanted to make sure that our reimbursement recommendations really aligned with the difference in relative inputs that go into rendering these services. And that's how we ended up using relative value units. Relative value units is a metric that Medicare uses right now to differentiate the input required to provide different levels of care. So the relative value unit system for ambulance services is based around an RVU of 1, which represents 1 unit of non-emergency basic life support. And then it sort of just goes up from there. So if it's non-emergency advanced life support, the RVU level would be higher. If it's basic life support emergency, the RVU level would be higher. And this was a system that really differentiates level of care in a way that takes into account some of the differences in cost across these different services. It's also a standardized approach that's utilized currently by the Centers for Medicare and Medicaid Services. So we ended up recommending using RVUs to create rates that were specific to the level of care provided. And another thing that we also utilized based on current Medicare methodologies is looking at the geographic adjustment factors. So a lot of discussion took place throughout this study about various licensed EMS units operating in various areas and considering the differences in costs that may be incurred when you're in one of those designated super rural areas, which is the lowest 25% of the rural areas, or when you're operating in a rural area where you may have to travel farther, it may take longer to provide a typical response. So we were able to utilize a methodology that aligns with the Medicare approach in order to differentiate the cost so that there's a slightly higher cost for rural and then a significantly higher cost or rate associated with those super rural areas. All right, so at this point, we've got our cost, we've got our transports, we've made the determination to use the Medicare methodology as the basis for developing our rate recommendations. And so in order to apply relative value units, we need what's called a base rate, which is a fixed dollar amount that the relative value units are multiplied by to get to the rate. And so we were able to calculate a base rate by looking at that overall cost, and we were able to allocate cost across 3 buckets. So we looked at the universe of spending on 1 year's worth of ambulance services, And we determined a portion of the cost which was associated with vehicles, which went directly to setting the mileage rate. And then of the remaining costs, which went to responding, we allocated a portion of cost to treat no transport responses and a portion of cost to responses that did yield a transport. So we've got for each of those three buckets our cost basis, and we were able to use the ratio of cost to total responses. So for the transports, we looked at total transports as the denominator. For treat no transport, we looked at instances where medical care was provided and no transport occurred as the denominator. And then for looking at vehicle costs that was used to set the mileage rate, we looked at the number of transports multiplied by an average miles per transport of 4. And we used the median there based on some of the claims data that we received. So it was 4 times the number of transports was the denominator for calculating the mileage rate. So we used that data to calculate a base rate, which is the foundation for applying relative value units. So we would multiply that by the number of relative value units associated with a particular service type. So let's say emergency basic life support. And then we also applied those geographical adjustment factors, and that allowed us to arrive at a distinct rate by procedure code. And these are the rates. So I think this may be our last slide. Take one more look. So we've got our recommended rates, and I mentioned our 3 buckets. So this is the first of the 3. This is the rates that are associated with transports, and we do have another slide specifically on mileage. These are the rates associated with treat no transport responses. So one thing that came up when we were working on developing treat no transport rates is that treat no transport is a really wide universe of possible scenarios. And examples were a lift assist as something that might be on the lower end of intensity needed to render the service. It's something that can be done quickly and then allows a unit to return to readiness. But another example was a cardiac arrest patient, somebody who requires really intensive on-scene treatment that may require an hour or more of a response team's time, but then refuses treatment to a hospital emergency department. So we wanted to set rates that really acknowledged that there's a wide array of care that can be provided under this bucket of treat no transport. And so that's how we arrived at a distinct treat no transport rate for basic life support, ALS 1, and ALS 2. And here we've got our recommended mileage rates. I think one last point that I really want to make while we're looking at the rates is that on the transport side, our rate recommendations were based on the timing of the survey, so back in December of 2024. So we compared to Medicare reimbursement during 2024 and found that the transport rates were 209% of the Medicare reimbursement levels in the state at the time. Or sorry, I said it backwards, 202%, and the mileage rate was 209%. But I really want to emphasize this third category, which is currently not reimbursed at all by Medicare. So these would be brand new reimbursable services, which historically have been provided across a range of payers and go unreimbursed. All right, so the last thing I'll say is at this point, once the rate recommendations were finalized, we did hand our analysis over to our Lewis and Ellis counterparts, and they found that the impact on insurance premiums was 0.1%. So not a major impact of adopting our recommendations, given just the many factors that affect insurance premium cost.
Hi, Megan.
Hi.
My name is Justin Barron. I chair the board of Stewart's Ambulance and also Municipal Resources. I want to thank you. It seems like you guys and the NHID did an unbelievably comprehensive job here of pulling together all of this data, and I think all of it's really, really helpful. What's scaring me is if I'm understanding correctly the study, if we adopt it for only the regulated NHID companies. We're about to create an immediate $75 million funding gap for EMS statewide, which is already in crisis. And what I mean by that is I think what I heard you say is, for example, we operate in Meredith, New Hampshire.
Yep.
Meredith pays us $250,000 property tax subsidy. When you figured out our costs, you deducted the $250,000 property tax subsidy, which makes complete sense. But then what I also heard in the executive summary is that you assume all payers, Medicare and Medicaid, are going to start paying your new rates. And because they're all going to start covering costs. And according to the most recent numbers I could get from Director Lippman's office, if all of a sudden Medicaid starts reimbursing that to meet our costs, the state of New Hampshire's budget has to come up with an additional $11.4 million immediately, or there's an $11.4 million funding shortfall just from Medicaid baked into the study. And on a federal level, our federal delegation has to immediately secure at least $64 million in funding, or this will create an additional $64 million immediate funding gap for EMS. Because this assumes everybody's going to cut. Starting from what I've seen of the governor's budget, there's no $11.4 million bailout. And what I've heard at a federal level is there's no $65 million bailout of EMS. And this is after already factoring in all of the taxpayer subsidies that are getting paid today. So on top of those taxpayer subsidies, which are factored into the study, just in those two payer groups, it looks like it's about a $75 million shortfall. And we're all struggling to keep our doors open right now with the $75 million shortfall. And I guess it's actually more than 75 million, because part of our costs that are in there right now are all of our treat no transports, which seems like those were broken out as a separate cost, not reimbursed. Currently, we roll it into some of the stuff that we billed for, but unless there's enabling legislation immediately from the Department of Safety or the NHID, that's an additional funding gap. And if we get out of state insurance companies who piggyback onto the NHID rate, that's going to cause another. So how are we planning? I understand that we're looking at a very, very small sliver of calls, just the NHID. But this would formalize this huge funding gap immediately. And how do we all continue to respond to calls with that big of funding?
So I think we're talking about a couple different, you brought up a lot of issues, but the purpose of today is really to get into the methodology behind the study. And the study had, as we said at the start, certain parameters that were how the study was to be completed. So that's what Megan is here to answer questions on. And I think a lot of what you're bringing up is stuff really for the legislature to address. If we're talking about funding sources, that's really those are legislative solutions. There's nothing we can do at insurance. There's nothing safety can do. There's nothing PCG can do to fix any of those issues. What we were trying to do here with the study is come up with a cost-based analysis,
Sure.
and this is limited to insurance.
I'm just did I understand the methodology? Does this assume Medicare is going to pay twice Medicare? I understand. Can you roll back to the executive summary? Is that possible?
Yep.
Maybe I'm missing something.
So let me just,
Second bullet there.
there you go.
All public and commercial payers in the state are paying at the same rate. Am I understanding correctly that the methodology assumes Medicare's paying the same rate as you just put up the screen and Medicaid's paying the same rate as you just?
I think you're understanding it correctly, but there's another way to think about it, which is the scope of this study was just commercial insurance. So if we had taken your overall cost universe and limited it to just the cost of transports, let's say, and this is just purely me using dummy data, but let's say 20% of transports in the state are reimbursed by commercial insurance, we would have taken that 20% transport count and we would have used a starting point of cost that represented 20% of overall spending.
Yeah.
So we would assume that the average response provided to somebody with commercial insurance aligns with the average response provided to somebody with Medicaid. And that smaller sliver would have been the focus of our study, and we would have arrived at these same recommendations. And there's one other clarification that I want to make here. You mentioned the taxpayer dollars that are earmarked for EMS that are netted out of total cost. I think one important point that I failed to mention previously is we also applied something called a provision for adverse deviation. That provision for adverse deviation amounted to a 20% addition to the sum of all costs that ended up being included for licensed EMS units. So we were inflating that cost up by 20%. And that resulted in 102.44% of overall cost. So even when we factor in that we had netted out a portion of cost for those taxes earmarked for EMS, the provision for adverse deviation more than made up for it when we look at the positive adjustment that was made. So where we landed was reimbursement rates that are based on a universe of costs that was a little bit higher than the total cost incurred by licensed EMS units, even before we net out or consider any adjustments.
But from a methodology standpoint, it still assumes that we're gonna see a double in the underlying methodology of the study assumes that the state is gonna over double their reimbursement rate and the feds are gonna double their reimbursement rate. And if municipalities are currently using balance billing to offset that, that's gonna create a major immediate property taxpayer fund.
Yeah, and I'll just reiterate what Michelle said
Yeah,
here.
That is the purpose of the underlying legislation. SB 407 from last year was really to arrive at what are the costs for providing these services in the commercial insurance space. One of the underlying reasons for this was to prohibit cost shifting. So not charging commercial insurance enough to compensate for the fact that you're not getting enough from other payers. And that was built into some of the structure of this study. So this cost study arrives at what is the true cost of providing these services for commercially insured people. It does not fix all of the issues, and it was never intended to do so.
But that also means everybody needs to be clear. I'm not saying that insurance companies should pay for the cost. I'm saying we're looking at an immediate shift where property taxpayers now have to step in and build under this.
No, I don't think we're causing a void though, because if Medicare and Medicaid are not necessarily changing from what they're doing today. So that bucket of money you're already getting from them isn't changing.
So if
So
communities have chosen to use balance historically to cover some of what Medicare and Medicaid don't pay for, and that goes away, property taxpayers have to now foot a larger bill.
but we're talking about balance billing for those commercial insured people, which is the point of this cost study. If this is what the cost is to provide the services for these people, then why would they get billed more?
Because what
And I think we're going more into the legislative discussion
I'm
here.
not saying I disagree, but what we're fundamentally saying is we're gonna change how we do this. Insurance companies, it's not fair for them to pay more than their fair share. That cost needs to fall on property taxpayers. And so property taxpayers have got to pay for this because we're not gonna let you charge more to insurance companies anymore than cost. You don't get to do that. That practice is done now, which is fine. But there's this $100 million shortfall that somebody's got to pay for. And since we can't put it on the insurance companies anymore, it's property taxpayers. That's what we're doing.
I think these are issues that the legislative body needs to figure out and are not really what this cost study was meant to do. So, go ahead.
Thank you. I do have some questions about the underlying model, Representative Stringer from Lincoln and Woodstock. And it's great that we're talking about the rate of revenue and the public funds remain constant. So I'm trying to understand exactly what costs ambulance services incurred that we then subtract out and for what reasons. For example, if they go do a fundraiser, like if you have 5 of these T-shirts at home for the Linwood ambulance running with the Bears, do those charity funds that are raised come out as public funds? And then, of course, do monies paid by cities and towns to supplement the services, have they been removed basically from the numerator, the total cost that we then need to have covered, divided by the number of services split out among all the different codes are done. So I'm hoping that you can explain that or clarify that.
So I can clarify exactly what we used. This is data that came straight out of the GAD surveys that Medicare put out, and they have a spot where the licensed EMS units report their revenue from billing for services. And then there's a separate prompt which has a laundry list of categories of other types of revenue that may be collected. We pinpointed our reductions to just those that fell under taxpayer dollars earmarked for EMS. So my understanding is that would not include many of these examples that you've laid out, but we didn't go back and ask every licensed EMS unit, hey, we noticed that you had some taxpayer dollars earmarked for EMS, what was in there? So I can't definitively say. And these Medicare ground ambulance data collection survey responses are subject to audit, but they haven't been audited. So the underlying data is sort of the best that we had available.
So let me ask, what do you think would happen, like in Franconia, the ambulance service was shut down 2 years ago. They pay, I believe, $750,000 to the Littleton service to come and take care of them. How would that $750,000 be reviewed? Would that be considered now a non-cost? So service, or is it still part of the costs that they have to cover in order to provide the service?
I wouldn't consider it a non-cost. The cost to provide the service is really, there's two key buckets, personnel and non-personnel. And then within each bucket, for personnel, there's the response personnel. So folks like EMTs, paramedics, and that cost is what they're actually incurring to provide these services for a year, whether they're just serving their own community or they're also incurring costs to serve a neighboring community. So my expectation would be, as a result of that shift, the cost would have increased and that cost basis would reflect that.
So it sounds like you're saying you still have the same total cost. Now you have two different essentially revenue buckets. One is the amount we want reimbursed for services provided. And then the other reimbursement is those provided by government entities, I guess. And when you come up with your final rates, you're just using the piece of it that you've subtracted all that other cost. So you only need enough reimbursement to cover that other piece. Does that kind of sound about right?
Yeah, although I want to be clear again, it's taxpayer dollars earmarked for EMS. And the scenario that you're describing where one community is making a payment to another community to provide services on their behalf, so it's more of an intergovernmental transfer of funds, would, in my expectation, not be reported as taxpayer dollars earmarked for EMS and wouldn't be subject to that reduction.
Do you have an idea how big that taxpayer dollars was in relation to the total cost of EMS services for the state?
I can tell you exactly. Hang on. So it worked out to 20.9 million of 134 million in the universe of total cost. Yeah, around there. And again, we also applied a provision for adverse deviation of 20%. So we reduced by about 17%, increased by about 20%. And that's how we came to that 102. Okay.
Services. And I'm wondering, is that for just services provided within the state, including to people who live in other states, or would they be excluded if somebody from Massachusetts broke their leg and went out?
We did get that question and we defined it as pickups in the state. So it could be an out-of-state resident, happens to be in New Hampshire that day, needs an ambulance, and that would be included. But I will say for the bulk of those, they were large licensed EMS units that operate in many states, and the percentage associated with the services rendered within the state of New Hampshire was a small percentage.
Question on the volunteer adjustment, just couldn't quite 100% follow. So, I mean, part of the reason why the ambulance services somewhat collapsed in the state is because a lot of services that were provided by volunteers, combination of readiness requirements and availability of volunteers anymore has changed the nature of the business. So even those that are heavily volunteers now probably won't be for that long. So, did I understand correctly that you made an adjustment for volunteer work, that you were assigning a cash value to what they're doing?
That's right. So just to use a straightforward math, I'll say $50,000 is the cost of one professional that's a volunteer. We would increase the overall cost if you indicated that you had one full-time person at that level operating within your licensed EMS unit on a volunteer basis.
So if you have, accounting for all the volunteer adjustments you had, how much of the total cost was due to a volunteer rate adjustment? That's the right way to ask the question.
I think you asked it perfectly. I don't know the number offhand, but I will say it wasn't huge. There were not a ton of respondents and participating licensed EMS units that indicated that they used volunteers. So it had a material impact, but it wasn't 10%, 20%, 30%. It was on the smaller side. Yeah, we can get you that.
If I might, just want to try to put in a little bit better system here. Got a lot of folks in the room, a lot of folks have questions. Let's do this. Could we have one question, then one follow-up, then get on to the next person, then we'll circle back around if you have more. This way there, everybody gets the opportunity to be heard. I don't want anybody getting frustrated. Good. All great questions and points so far. I don't need to pass judgment on them. We just want to make sure everybody gets an opportunity. Sorry? Okay, yep, Representative Spear, and then we're going up top. You guys have been waiting.
We went very quickly over the where there's no transport,
Yeah.
and it seemed like it was considerably lower than when there is a transport to a hospital. But the treatment can be very significant. Can you explain, and this may be my own naivete, but can you explain why it's so much lower? I mean, when the only piece that's taken out is driving, well, and you have to do some support, of course, obviously,
Yep.
while they're in the transport. Why it's so much less?
So we consulted with our subject matter experts who are former fire chiefs that have rendered these services to try to come up with an assumption. And at the end of the day, we're looking at one pool of costs. So the same total dollars is getting split across treat no transport and transport responses. So any decision we make is going to result in revenues, just whether more of the payments are on the treat no transport side with higher rates there that would reduce the rates on the transport side. But ultimately, the decision that we made was to prorate the cost associated with treat no transport at 50 cents on the dollar. And the reason that we got there is because our understanding is, number one, the average treat no transport response doesn't take as long. And you're right, a big part of it is that when you do a typical emergency department transport, you're moving in a triangle. You're going to the scene, you're going to the emergency department. Often there's a significant amount of wait time and coordination at the emergency department before you're able to return to the station or wherever you're based and resume readiness. Whereas the typical treat in place is just an out and back. So the time piece of it was a big driver. Another assumption that was made is that often the treat no transport responses are lower acuity that don't take as long. If somebody is in a scenario that requires intensive care, they're much more likely to need the transport.
There's a question up here. Yes, sir. Thank you for taking the time today and explaining this. Appears to be a very nice job on
On page 19, and you previously touched on it, or as a part of the data stream as to how you came to the conclusion to use 73 samples. There were 12 that were eliminated for your IQR process. One, could you just go over how that formula worked? And then I would be interested to understand how many were in that first, what, 14? And then in the highest, to just better understand how that may have impacted what we're using as well on a bell curve, where we're going to put that center.
Yep. So the distribution was skewed more towards the lowest quartile. So I'll turn to face the same direction as you. It sort of looked like this. And so when we used the 1.5 times IQR, and specifically the reason it was selected is because it's a statistically valid method for scenarios like the distribution that we were looking at. It wasn't a normal distribution. It wasn't a nice even curve. And so the way that the math works is you take the first quartile, third quartile, so sort of the bounds, and then 50% of all participants are in between these two bounds, so the second and third quartiles. So that is the interquartile range. We multiplied by that range by 1.5%, and then we went out 1.5% of the IQR in this direction and 1.5% of the IQR in this direction. When we went on the lower end, we ended up with a number that was far below 0. So we did not exclude any of the 12 on the lower end. All 12 were excluded on the upper end. And one of the considerations there, if we kind of go back to the bottom underlying enabling legislation component here, cost estimates shall assume that services shall be provided in a reasonably cost-effective manner. And that was one of the underlying parameters that we were faced with as we began this study, and one of the reasons behind excluding some of those that were truly high-cost outliers.
Yes.
No, unfortunately, as part of the basis for this cost study, we did collect commercial information from the underlying providers throughout the state. And as part of that process, there are confidentiality requirements. So we cannot disclose any specifics about any of the individual underlying units. We're only disclosing aggregated data. So the data that's in the report has all been aggregated. So we can't identify any of the individual respondents to any of the surveys. Because not all of the licensed units that responded are government entities. There are some private entities. Their, cost reimbursement. This is a lot of sensitive financial information. So it is confidential information, and under 91A typically would be not disclosable. So as part of this underlying legislation, there is going to be no disclosure of any of that individual level data for any one provider, and that we're only disclosing aggregate information. So the report is on an aggregate level. So we're not calling out any individual provider and saying, wow, your guys' costs are out of control, or, this one gets the gold star because they're the best, or anything like that. So it's only on an aggregate level, and we will not be disclosing any individuals data.
Thank you.
We go up to that corner.
Thank you. So my question is referring to your taxpayer dollar earmark for EMS. So is that an assumption that EMS is a required service? And how do you figure that for a municipal fire or EMS department?
So that is based entirely on the GADS data. I don't think there's any underlying assumption about whether EMS is classified as a required service. It's just the intent is to capture the instances where revenue was received from taxpayer dollars earmarked for EMS towards the provision of those services.
But would you say that those are still expensive for EMS?
Yeah, it specifically says earmarked for EMS. So those.
They don't count for.
So we use them as a net adjustment. So they're a reduction to the cost of EMS. So that's not the term I would use. I would say these are dollars that are used to support the provision of EMS services. They're revenue received to support EMS. So they're not part of the cost, whether or not a licensed EMS unit is collecting taxpayer dollars. They're still paying their EMTs and their paramedics. They're still incurring cost to keep their vehicles on the roads. That's independent from any revenue collection. Those are two completely different things. Without the provision of EMS, there wouldn't be EMS cost.
So if we were to, this involves New Hampshire commercial insurance, and it sets a rate that would be by New Hampshire commercial insurance, which would eliminate the need for balance billing. Currently, we balance bill everybody else to try to do it. Is it fair to extrapolate this in the other direction and say, we have to match it on tomorrow? If everybody we bill for an ambulance call paid us this rate, there would be no need for taxpayer funding. Is that why you back that out?
No, so the reason that we backed that out was because of the enabling legislation, which specifically had a provision that we would consider that. These rates are based on the assumption that that continues. So if everyone pays, although I will say, I'll reiterate, the provision for adverse deviation again sort of offsets the impact of that adjustment. And then results in a cost basis that's a little higher than the total EMS cost incurred by the universe of included licensed EMS units. But it doesn't necessarily mean that no one has a need for taxpayer dollars if these revenues are adopted. And one thing that we did see, and I mentioned the distribution, significant variability in cost incurred.
So the attempt of this study, and again, just to clarify for me, is not to set a rate that would provide for a self-sustaining EMS in the state of New Hampshire. Is that correct?
The intent of this, yeah,
Yeah.
you want this one?
So that was not the intent of SB 405. 405 was just to do a cost analysis of how much does it cost to provide these services in the context of commercial insurance markets. And I think Jen has a,
He's got someone online that will swing back over.
Excuse me, thank you. Yes, Senator This is joining us online. Excuse me, but she's having some problems with calling in, so she texted me a couple questions I'm gonna ask.
Sounds good.
Senator Prentice. Was the financial fall off that will be created by this change calculated? Many non-fully funded insurers currently pay well above Medicare. Many pay full charges. They will likely stop doing that if a rate is established. So will auto insurance and workers' comp carriers does the report address this?
The report doesn't address this. I will say the actuarial analysis assumed that every commercial payer is paying exactly these rates. In practice, these rates are the floor for reimbursement for commercial carriers. So it is possible that commercial carriers would pay above these rates under certain circumstances. But it did not look into specifically scenarios where there's a range of commercial reimbursement. It assumed uniform payment at these rates.
It's not a big set of proposals. Assuming that all payers pay those rates. How many transports does a municipality need to provide? 100% paid transports, those municipalities need to provide to break even.
That is going to vary significantly by unit.
Based on the cost information that you have, you should be able to say, I think you'd be able to say, municipality needs to do on average 1,500 paid transports to support their EMS system.
I can tell you that our pool of underlying cost was $134 million. And I can tell you that our pool of included transports was, let me grab the number for you, 134,753, and then 23,052 treat no transport responses. And the assumption on the mileage side is that for each of those transports, there's 4 miles on average, but it's a very distinct to each licensed EMS unit. Everybody's structured differently, everybody's cost is different. And so you're not going to end up in a scenario where everyone is at 100%. So our estimate, and again, we worked with our actuarial team to come up with this, was that a little over 80% would achieve cost recovery. 80% of transports would achieve cost recovery when we're looking just at the direct cost. So the cost of the staff on the vehicle, the cost of the ambulance itself, the cost of equipment used in service delivery. When we're looking at the full universe of spending, that number goes down to just under 70%.
And that's assuming a 4-mile transport.
Assuming a 4-mile transport and assuming everybody's sort of at their current cost structures. So what that says is there are providers that are on the lower cost end that are making more than what their cost is. And then there's that 30% of providers on the higher cost end that would be in a situation where adopting these rates would not result in full cost recovery. And I say providers, but specifically it's looking at the transport volume.
That's specific to transport.
Right.
Including treatment.
Right back there in the corner.
First, when you did your research, with the treatment of transport, I saw that, and I said, I'm gonna laugh. So the numbers sound a little high. Medicare does not reimburse treatment of transport. In New Hampshire, I don't know, can you find out how many services actually charge?
So we didn't look at revenues associated with treat no transport. We do have all payer claims data and didn't see a significant volume of reimbursement under that A0998 code. But our underlying understanding is that this is not a service that's often paid. These are services that the bulk of providers are not billing and currently getting reimbursed for.
I don't know. These free services for our people. We have the option to, well, we haven't been, but you could be forcing us into having to go in and say, hey, we helped you. Now produce your insurance card, get something like this passed. Second, the 12 that were excluded because they were too high. Did you actually take any methodology to find out, were they really too high or actually is everyone else too low based on the national average? Because one of the other things that I didn't see noted, but it might have been, is New Hampshire has one of, if not the lowest Medicaid reimbursement in the entire US. So we're already behind the 8 ball. And we could be increasing our fees all the time. I mean, the cost of medical equipment goes up an average of 5 to 7% every year. But we don't change our ambulance rates every year.
So when
Like this could drive us into having to change our ambulance rates every year. Some departments and agencies don't change their rates for 10 plus years. And this is all directly going to impact, and I just didn't see that accounted for in the study.
So I guess one point I'll make is, again, there's cost, which is what we really focused on, is from the survey data collection that we did, what is the cost to render these services? And I think if your argument seems more like it centers around charges, which is what you're billing out to carriers and individuals when services are rendered, which you're not actively increasing. But the cost looks at the reality of what was paid during that set 1-year data collection period to be able to provide the ambulance responses that you provided.
Just to clarify, Medicaid rates are at Medicare right now. They did get increased recently. And should any legislation get passed, that's not going to force anyone to bill. It's just if you bill, these are the rates you're going to get. So just anyone.
But we can't run in a deficit. That's what I'm saying. Like there are things that are not, I don't think you account for. You say some of your numbers were based on this is what it costs you to operate. You pay
an individual 50,000 a year. But to buy a monitored defibrillator that has to be replaced every, 7 years, that could be $35,000. And other, so these are the costs to operate the business, it's not just the individual. And I anticipate the formula of basing what the average salary, but it's the average service, the cost of living. I know what Medicare or Medicaid will pay you back, but it's always been historically under what we spend out. We just have to live with it.
So I think it'd be helpful if you go over what is included in costs.
Yep. Yeah. So I mentioned earlier there's personnel and non-personnel. So within personnel, there's the responding personnel, which is your EMTs and your paramedics, folks that are on the vehicles doing responses. And then there's others that are in a role to support ambulance services, like you might have a director or administrative folks. That's the personnel bucket. It makes up about 80% of spending. But we did include a non-personnel bucket, which looked at equipment, so the cost of ownership, whether it's small equipment that you don't depreciate or large equipment where you have an annual depreciation expense or cost of ownership. We looked at vehicles, although that vehicle cost was utilized separately to calculate the proposed mileage rates. And then we also looked at the facilities, so your building depreciation, the space that you use to house your vehicles and your response staff. And then the last bucket's called other on the GADS report. And there's a lot in there. It's things like insurance cost. And I mean, one thing I will acknowledge is this is based on a moment in time. It's based on the data that we received, which was the 1-year data collection period. So you may be on the brink of investing in a large equipment item. If you did, the data would be updated not for the full $40,000, but for the annual depreciation cost of that item, which may be, let's say, $5,000. So it's not, the impact would maybe not be as big as what you might be envisioning. But again, we did inflate that. So when we got the cost, it's based on a set time period. It includes all these personnel and non-personnel cost factors. And then we sort of brought it up to the current cost as of the date of publication of the report.
I have a question online from Representative Gibbs.
Yeah, Representative Gibbs, if you could unmute and say your question.
Hello, this is Representative Merrill Gibbs. I actually have two questions, one very specific based on some of the information that you provided and the other more general. The specific question relates to what you said about excluding outliers. And I can understand in terms of the cost information provided by the various ambulance providers. I can understand excluding outliers, but I would think that normally that would mean excluding one or a few of the lowest cost outliers and one or a few of the highest cost outliers. But in fact, what you said was that you kept all of the lower cost outliers and excluded all of the higher cost outliers. And it occurs to me that that might cause a problem in your conclusions because you haven't, at least from what you said, you haven't factored in that some of the higher cost outliers might have reasons that they have higher costs. For instance, salary rates may have to be higher near the Massachusetts border than they are in the North Country. So do you think that that caused a problem or might have caused a problem in your conclusions?
Yeah, I heard the question. I think in terms of my initial response is that the reason we went with that 1.5 times IQR is because it's a statistically valid method for excluding outliers when you have a distribution similar to what we saw, where there is a very long tail of outliers on one end, but then a high concentration of sort of comparable average cost per transport rates on the other end. But I definitely think that's a valid point. I don't know if you want to.
So, but did you take that into account? Did you take that problem into account?
So our report used the 1.5 times IQR methodology to normalize the right skewed data. But we did consider other options, and based on our analysis, determined that this was the most appropriate based on the distribution of the data.
Okay, my general question, and I'm not sure this is a fair question, I may have misunderstood the invitation, but I joined this presentation to find out what you came up with, your conclusions and the reasons for those conclusions, which I would hope would be provided essentially in English rather than with charts, and with only those numbers immediately related to the conclusions. And so far, all I've heard is methodology. Which doesn't relate immediately to the conclusions. Are we going to come to the conclusions and the reasons for them?
So the point of this underlying study, as in SB 407, was to come up with this rate based off of the cost analysis. And that is what PCG did. And so that's what Megan is here to talk about, is the methodology and process they use to come up with those rates. I think this cost study is a basis for a lot of pending legislation right now. And so that is a different issue that we're not necessarily talking about today. We're just talking about the study and what went into the study to determine what those costs are and how they use those costs then to come up with suggested rates. Just to reiterate too, these rates have not been adopted in any way. This is just based off of the cost study, what their recommendation is. So this
Right,
doesn't necessarily change the landscape of what's going on right now.
And what I'm asking is, are we going to get to the recommendations and the reasons for them?
So I would argue that the methodology is the path to the recommendations and the reasons for them. But if you do have a specific question about an area of the recommendations that wasn't clearly addressed, I'm happy to expand.
Well, as I recall, the recommendation was 200% of the Medicare rate. And what I'm looking for is the reasons directly related to that.
Got it. So the 202% of the Medicare rate when we looked at the transport recommendations, and the 209% of the Medicare rate when we looked at the mileage recommendations, those were benchmarks. So those were included in the report to help people easily digest the recommendations and say, okay, this is how this compares to this other program. The recommendations themselves are actually the numbers associated with each procedure code, not the 202% or 209% of Medicare.
Yes, thank you. Something you've been anxious to talk about, provision for adverse deviation. So 20% of the costs that you're using are based on provision for adverse deviation. Why do you use 20%? Why not 10% or 50%? Or why have any percent? What was your thinking building this model for that?
So that was a parameter that was essential to the actuarial soundness of our analysis. And so that's a number that our team of actuaries that Lewis and Ellis came up with. They sort of evaluated the data, said that we want to make sure that these rates hold up under a range of circumstances, possible changes in scenarios, and recommended that we arrive at the 20% provision for adverse deviation.
Excuse me, can I finish my question?
So Megan's not the actuary, and because I was involved in it, I'll speak a little bit about this. I'm not an actuary either, but it's my understanding, and if I am misstepping, please jump in and correct me. But I think generally speaking, 15 to 20 is kind of a standard range, and the idea behind the pad is to help adjust for unexpected things. When you're doing any kind of actuarial analysis, you're trying to predict what's going to happen in the future, and nobody has a crystal ball. So they build in a pad, I believe, as part of practice to account for those things that you can't account for. And the actuaries we were working with felt that 15 to 20 is the standard range. And, the group working on it decided to go with 20 as being the best for this type of scenario.
You already call it a budge factor.
Yeah. The actuarially based fudge factor.
You wouldn't have gotten me to say yes to that, but I appreciate the question, no less.
Excuse me, I was cut off in the middle of a sentence. Can I finish my question?
Yes, go ahead.
Yes, go ahead, Representative. Go ahead,
Excuse me?
Representative Gibbs.
Go ahead.
Thank you. Yes, what we have to decide in the Commerce Committee is whether that 200% figure is the appropriate figure or whether we should use another figure. So that's why I was asking about not all the background information, but the specific reasons that you came up with that 200% figure and you think that's the appropriate figure.
Got it. So, I think Medicare benchmarking was not part of our recommendation. Our recommendation wasn't 202% of what Medicare pays. Medicare reimbursement is a moving target. So it was just a way to help highlight, here's how these recommended rates would compare to what Medicare is paying today. I think in terms of recommendations about how this information is adopted, I would argue that's more on the policy side and something that's being currently legislatively debated. Our charge was really, what does it cost to offer this range of services? And that's what these rates represent. They don't necessarily represent a recommendation that you set your rates to 202% of what Medicare pays. They just capture, as of the date of publication of the report, based on the data that we received, this is the cost-based rate calculation that we came up with.
But what I'm asking is not all the background numbers, but why? Why you think that that was an appropriate figure to provide?
I think that goes into the policy question. The SB 407 came about from last session where there was a lot of debate about ambulance bills. And what ultimately got passed was the decision to do this cost study to find out what is the actual cost of providing these services. And that's what this ultimately is. It's based on PCG's expertise, the data they've collected. These are the rates they would come that they're suggesting based off of how much it costs to provide these services, assuming those assumptions we've gone over. Representative Spear.
Thank you.
I was in the room when we decided to do this. And the idea was that from the Commerce Committee viewpoint, we can't solve the whole problem. There's at least three parts to the problem. There's a Medicare problem, a Medicaid problem, and an insurance problem for the commercial insured group. The commercial insured group out of that whole thing is the smallest group, but that is the only group the Commerce Committee can legislate. We expected that based on this information, that we would eventually have more bills, one that addressed Medicaid, which goes to a totally different committee, one that addressed Medicare, which has to go to our federal reps. But we didn't expect at any point that what we could legislate in the Commerce Committee would solve the whole problem. So I think we are expecting a few more bills to come along to go and aim at those other groups. We can only solve the portion that's the commercial insurance. That's all we have control over. So I think as a way to bound the commercial insurance cost, this is as good or better than anything we ever expected, with details that we never expected to see this level of competency. And we're very grateful for it. And we can move on just that percentage. Remember that the insured market is, the fully insured market is the smallest part of who uses the ambulance service. So more bills are required. And we'll be glad to help you write those bills, except that that's not what the intention of this of 407 is. It's just to address this one small part.
I see a lot of hands in the room. We have a question online from Chief Sitar from Tilton Northfield, so we'll pose his question out here and then we'll come back to the market.
Did PCG consider or determine the actual cost of service before any revenue was considered when determining the rate? If so, what was the cost for ALS 1 or A0427 rural? First and two questions.
So we did, we have again, the offset for taxpayer revenues earmarked for EMS is one parameter. We looked at the analysis with and without that, and ultimately the determination was made that in order to align with the enabling legislation and the underlying intent of the study, it would be necessary to include that offset. But that offset amounted to about 17% of spending. So, and it was applied entirely to the transport and treat no transport cost that was reported, not the mileage cost. So roughly a 17% increase in what the recommended rates would be for those transport and treat no transport buckets would be the impact.
Second question is, since tax revenue is considered to remain constant, do commercial rates recommended by your study rely on continued subsidy from the local taxpayers?
So I think the short answer is yes. And again, I'll go back to the enabling legislation. That was one of the parameters.
There, what is the specific cost for AL1 rural? And could you just reiterate how those rates are done? Like
Yep.
base rate?
Yeah, so we looked at the rural, urban, and super rural distribution and the acuity level, which is the way that we reference whether it's ALS 1, BLS, specialty care transport on a statewide basis. And we came up with an average. So for the relative value unit average, so the expected acuity level, how many RVUs are in a typical transport, we looked at data that was provided to us in the survey. So not only did we collect how many transports each licensed EMS unit provided, we knew how many of those transports were classified as ALS 1. And then similarly for the urban, rural, and super rural designation, we calculated an expected average adjustment factor associated with urban, rural, and super rural geography. And the way that we got there was a simple lookup of which zip codes within the state were classified in each of those buckets and how many people reside in each of those zip codes. So we went with the census data and looked at the population of each of these areas and assumed an even distribution of transports, which we know is likely not the reality, that any person is equally likely to need an ambulance transport on any given day. But it was sort of the best data available for us to come up with an estimate of what the average urban, rural, and super rural adjustment would be. So because we looked at it as a starting point, as a statewide average, that's how we got to our base rate. And then we used those relative value units and those three distinct adjustment factors for urban, rural, and super rural to come up with the specific rates that are associated with a particular procedure code in a particular geography. We did not create separate reimbursement models for each of these scenarios. So I don't have a rate model specific to just ALS in one particular area.
For fire department asked, where can I find if my community cost data was excluded as an outlier?
That information cannot be released.
That's if I'll take it right in the center, sir. Go ahead.
So I just want to go back to the methodology, and I'm not asking you to weigh in on the policy at all, but so if I'm understanding it correctly, the notion here is that ambulance services would build from everything up on the chart and everything up on the treatment transport chart. And so right now, we're a nonprofit 911 only service. We don't bill, if we go pick someone up off the floor, we don't send them the bill at all. And this would require, essentially assuming everything else is accurate and we didn't want to increase what we're charging the towns. Am I right? If I understand your methodology, that you would assume that I would now add a charge of $414 for picking someone up off the floor.
Yeah, I think that's a lot of licensed EMS unit specific policy making in there, but yeah, I think there would be, in order to be eligible to recoup these funds, you would have to alter your practices in such a way that you're able to pick up that, okay, this is a commercially insured individual that we just helped.
And what you're saying is, in those rates, assume that we're gonna start picking and charging grant on board before she goes and pick her up off the floor.
Yeah, ideally grandma's insurance company, but yes.
I think, correct me if I'm wrong, when we did the base rate calculation, that was for transports only.
So there's a distinct base rate for transports and a distinct base rate for treat no transport. And the transport base rate is based on the pool of non-vehicle costs that we allocated to transports. So you're absolutely right. There's a trade-off. It's the same starting point of total cost incurred by included licensed DMS units. And a portion of it, amounting to 123.7 million, ended up in the transport bucket. And then about 10.5 million ended up in the treat no transport bucket.
That's a real.
Clarification first and then a question. You use 4 miles for transport?
Yep.
Is that across urban, rural, and super rural?
We used it to set the base rate, which is the average rate, and then the urban, rural, and super rural are subject to different adjustments. So there's a 2% increase over the base rate for urban, a 3% increase over the base rate for rural, and then a 50% over the rural rate for super rural. Yep. So we were looking at it as a per mile reimbursement. So you would still be getting reimbursed for 16 miles at the new recommended rates. It wouldn't be capped at 4 miles or anything like that.
I think.
Still, it all goes back to the cost, right? So you're
Yeah.
determining the cost. 4 miles is, I'm not to my town line in 4 miles.
Yeah, I will say that this is an assumption that skews in your favor because the number of miles is the denominator for setting the rate here. So if the average is actually much higher than 4 per transport, you'd wind up with a lower rate.
And I think that 4 miles is
Question goes
key. Oh,
After
sorry.
the executive summary. You say that, you use the term reasonable operating margin. How did you determine what reasonable operating margin is?
So I keep going back to the 102.44% number, but that is a 2.44% margin over cost. And again, we consulted with our actuarial team to determine what a reasonable operating margin would be.
And how does that compare to our friends in the insurance industry on the other side? The insurance companies, what's their reasonable operating margin?
That's a much more complex issue, but insurers do have, by statute, limited operating margins and profits. So if you're talking about their profit or are you talking about their operating margin? Because
What are you talking?
we're talking, if we're talking about profits, usually they are capped. Like there's a medical loss ratio that limits the amount and you have to offset it and there's all these calculations. But I believe typically insurers operate on a 3 to 5% operating margin. But I don't know. I'm not sure. Industry, do you have anything to add to that? But that's typically.
But the other part of that is you talk about planning for readiness. Does planning for readiness include replacing the next monitor or replacing the next vehicle, or training and upstaffing? What's included in your factor for readiness?
So the way that we factored in readiness was we took cost, all spending to support ambulance services, and we split it into these 3 buckets: vehicle, transport, treat no transport response. We could have had a 4th bucket, which is readiness time. You're waiting for calls to come in, you're not responding, your vehicle's parked in the station. And we didn't do that intentionally so that the cost associated with the time spent being available to provide the service, even when you're not actively responding, is picked up and apportioned appropriately across the 3 buckets of cost that we included.
bill at this amount, which typically maybe they did 75% and the rest went back to the patient. And now the entire pool within that coverage is seeing an increase on the back.
Yes.
So at the beginning, we were told something had to be done because too much is being put on the individual taxpayer or patient. So whether they're paying it through their individual ambulance bill or through their premiums through their employer, whoever gives them insurance. I think that spreads out, but not saying it's a good thing. It puts the cost back on a larger pool of people than just the people utilizing services.
Yeah, I think that's a fair assessment. And that was part of our scope, was having an actuary come in and evaluate the impact on insurance premiums. I mentioned it came out to 0.1% of the cost of insurance premiums, so not going to be a huge cost driver to be passed on. And again, to your point, because it's spread out across individuals who may or may not be using ambulance services. But that was part of what we looked at.
Yeah, and I think generally speaking, anytime you're increasing the cost, that needs to be accounted for, and that will drive up premiums. Sent to which is what we do the actuarial analysis for, to figure out how much it's going to evaluate. So if you look in the report, there's a section about the actuarial analysis, and that goes into a lot more detail about what they did and what their estimates are, assuming these specific rates went through. If you have a different set of rates, it's going to skew that actuarial analysis.
Representative Stringer, go ahead.
The question on the RVUs, and breakdown into individual on the model. I think I read that you use the Medicare RVUs as a base and then factored them up or down and didn't apportion costs individually between the group and
Yep.
do the whole RVUs. Was that correct?
That's correct. And the reason for that is we do not have an alternate method to apportion cost across the categories. So if I was just going to make a general assumption and say I want to apportion some of the cost to advanced life support versus basic life support, I could look at what percentage of the transports fell in each of those categories, but then I'd wind up with the same rate across ALS and BLS. So RVUs were a tool that we used to make sure the rates were appropriate in proportion to one another.
Second question is in your data, is there anything where you captured how much was billed for balance billing and collected for balance billing? And does anything out of that report say how much billed revenue and actual revenue goes away?
So we did look into this. Our conclusion was there is not clear data available. There are some fields on the GADs for associated with billing revenue. There's fields with each category of billing revenue. So let's say we're talking about commercial insurance for cost sharing. That's really intended to be your patient copays and things like that, not your balance billing. And then there's a separate field for patient revenue, but it's unclear what portion of that might be self-insured, folks that are uninsured, folks that are paying out of pocket because of that, and what portion might be balance billing to individuals with commercial insurance coverage. So we didn't have the data to answer that question. Oh no. I was hoping you weren't going to bring her into this.
So of course, grandma has Medicare. Medicare isn't going to pay us for that, right? Because they, you don't pay us for that. Am I right thinking that your model assumes that Medicare will start paying for that? Or if it doesn't, your model assumes that that money is going to need to come from some other source. And I know that, the other source would be a policy question, but math says that Medicare is going to pay us for that, right?
Yeah, I mean, I think it goes back to your original question and sort of the point that you made here, which is this was a study that really lives in the bubble of commercial insurance. So we are assuming one of two things: either all activity is commercial or everybody else is doing the same thing that the commercial carriers are doing. We know that's not the reality of how these policies will take effect, but that was the parameters of the study that we undertook.
Seems like if every Medicare patient that we go out and pick up on don't get paid for them, that's built into this assumption that that's what we against me, but that is going to result in, I don't know what the numbers are going to be, but a significant shortfall. And I just want to make sure that I'm understanding that now. And are you able to quantify what that number would be?
So
Say commercial insurance is the only, because it really is going to impact taxpayers, right? So.
yeah, I don't have the answer of what the number would be if in a universe where the only payer that existed was commercial insurance. But I can provide a little more clarity into what the impact of the billing associated with the treat no transport responses would be. So we looked at it really as apples to apples. So when we gave you that 202%, where we're saying that our treat note or our transport rate is the equivalent of 202% of what Medicare paid back in 2014 in the state of New Hampshire. So it's apples to apples. And we didn't do a Medicare comparison for treat no transport because Medicare doesn't currently cover treat no transport. Had we lumped in treat no transport when we were looking at that Medicare benchmark, it would be 220%.
Just so I make sure I understand. The one part that was new to me today is that is after factoring in existing taxpayer payments. So if I'm thinking about this right, I guess if I'm in a community, we all get huge taxpayer support every single year. So if I'm in a community where I warrant article my ambulances, and those ambulances at $450,000 are paid 100% by property taxpayers last year, you're saying that's not a cost that's going to be reimbursed by any of the payers because ambulances are already paid for by property taxpayers. And so 2 times Medicare, I know you don't like the benchmark, but 2 times Medicare already assumes all the taxpayer subsidies that all of us are getting are due. And then on top are going to continue. And then on top of that, which I understand, Representative, is outside the scope of commerce, but there are all these other funding gaps. We're going to have to start charging $500 for treat no transport. We're going to have to get Medicare to double their funding. We're going to have to get the state to double their funding. Or we're going to be looking at, and I'm speaking on behalf of MRI here as much as Stewart's, catastrophic level defunding of EMS statewide. You're looking at well north of $100 million drop, in addition to the taxpayer funding that's already being provided. Because I'm willing to back the majority of us if you foreign articles to buy ambulances in the past. And that deducts that from the cost. Am I thinking about all those numbers right?
No, I don't think so.
I don't think so.
Okay.
You were at 50 million earlier, then it went to 75, and now it's 100 million. That's some kind of inflation.
And I'm trying to capture what the pieces that are, so am I right in understanding that all taxpayer subsidies that went to EMS agencies last year have been netted out of cost?
For the universe of the 73 included ambulance providers, if on their GAD survey they indicated an amount of license or of taxpayer dollars earmarked for EMS, that was netted out of cost.
I mean, that's what I'm saying, Jason. The more we're learning about the study, and to McGregor's point, I didn't think about the treat no transport.
No, there's something
I didn't think there keep being all these components.
There's something not quite right about that. All right, so the amount of money that was paid as by the town for the ambulance service, that went into the basis of the cost study. There was nothing whatsoever that says if an insured person requires the service, that they don't get billed. They will get billed.
No, Megan,
And you will bill it.
deducted that.
No, she deducted it for the cost evaluation,
Yeah.
to establish a cost evaluation. An ambulance, if I have a certain insurance, and even though the town is paying for some value of the insurance, for the purposes of billing the insurance company, you still get to bill them.
No, that's what she's saying, if I'm understanding it.
No.
You don't get to bill them for whatever taxpayers pay for.
Oh, no, that's not true at all. I'm glad that we clarified that. So no, the taxpayer dollars earmarked for EMS were part of the development of these rates. the underlying expectation is that every provider is going to be billing commercial insurance and receiving these rates 100% of the time, whether there's
Would make it, and taxpayers that subsidize EMS. For those dollars deducted from costs.
they were deducted from the costs that we used to arrive at these rates.
Yeah,
Yes.
so that, those billing rates do not reflect the amount of subsidy that everybody's already getting. Or it does.
Well, they do reflect the amount of
They're
subsidy.
not getting paid. Those rates mean they're not getting paid for anything taxpayers at this sort of thing, like ambulance.
Right. Or another way to say it would be exactly how it's laid out here. The rate of revenue received for ground ambulance services in the state through public funds remains constant. So it assumes that you are continuing to receive taxpayer dollars at a level comparable to what you're getting today.
I think when you're talking about shortfalls though, I think this is getting a little bit into the policy stuff, but these rates are just for commercial. So whatever gets passed legislative wise, say it was these rates, whatever you're receiving for Medicare, Medicaid, the vast majority of the services doesn't change. The only thing that's really changing in these rates are the commercial insurance bucket, which is a much smaller bucket. So when you're saying catastrophic shortfalls, I mean, if there's catastrophic shortfalls now, then that's not going to change. But this is not changing the rates for some of these other services, which make up the bulk of the services. So I'm just not really sure where you're talking about the shortfalls.
So if you look on the NHID health cost website, what you will pay number for ambulance is very different than the rates that you came up with. They're much higher according to the NHID. And so I think a part of that is because of balance billing, right? And so if all of a sudden, unless I'm misunderstanding it, Jason, if all of a sudden the what you will pay drops significantly, that means somebody's got to come up with that funding. And I think part of what I appreciate to the comprehensiveness of the study is it does highlight the fact that the federal government pays less than half of the cost for all of our services, and we're expecting property taxpayers to pay it. That's not a criticism of the NHID. It's just a fact that came out of the study. The Medicaid program expects to pay less than half the cost of these services. And that maybe to survive, we've now got to start charging residents $500 when we show up at their house. That's, nobody's ever, to the best of my knowledge, any of us done this? No. So that's going to be a big surprise. And that's one of the things in the study. And I think we've just got to make sure this is all comprehensive.
No, this bill is never going to be comprehensive. This bill only addresses one small part. We need another bill for Medicare. We need another bill for ERISA. We need another bill for Medicaid. This is only one bill. You need at least 3 or 4 others.
I agree with you. I absolutely.
So let's get started on the other bills.
Yeah.
Well, I will point out,
This is not gonna solve all that.
I do want to touch on your, sorry, go ahead.
And my question is, one of the 12 communities that got excluded because we're fire-based and we have higher costs, how does that adversely affect us? Because I can tell you that it's not the rural volunteers that are losing on those 12 communities that got cut out of your service. So the delta for us is going to be even more than the delta for everybody else.
So I don't believe we've disclosed who's been excluded,
That's the
so,
problem.
so that's part of it, but
Down to fire department and fire EMS, just a ratio.
I don't think so because of the small sample size. I would have to look into that, but we can't disclose it, some information that would allow you to then identify confidential information. That wouldn't be allowed. But,
Required that to separate.
Ethan, hold on, let's speak still. Go ahead, sir. So I mean, I think too, when we're talking about this distribution and the people who, the 12 that got excluded, they are way out here. Everyone else is in the middle. I think that's the part of the distribution. If we had the actual bell curve or a whiteboard, we could draw this. But most of the people are within this bell curve, and then this tail went way far out. So the people who got excluded are nowhere near these other ones. And that's statistically, that's the 1.5 IQR. Statistically, they are a huge outlier, and that's the reason why they're getting excluded. But
12 out of 100 is statistically insignificant.
It's not insignificant, it's just that their cost, for whatever reason, and we didn't get into that stuff, that was not the purpose of this study, was to get into why our is so high, and it could be,
If you're saying 12% doesn't matter, because you don't like the cost, then either just say the cost doesn't matter and we don't care about the numbers.
I don't think that's at all, I mean, Jason, you wanna eat
So
that?
the process is called, you have to screen out for implausible cost report.
So our numbers are wrong.
They call them plausible based on. Give me a chance.
No, I'm just.
It's called implausible reporting because of the distribution. It's hard to believe that the median level is in the middle. And that there are these, it costs inherently that much more in the state of New Hampshire to operate an ambulance. So they're way out to the right. And so that's why they get screened out. The reason why we did a one-tail screening, not two-tailed, is because to meet the condition of cost efficacy, we didn't want to screen out EMS units that were very cost efficient at providing services. But you can see in the distribution that there were some outlandishly high cost reports. They have to be screened out because otherwise you have non-normal data that would be basing the entire cost report off of, and that would be statistically invalid. So we had to do that. It's called implausible cost reporting.
So 12%.
That's data.
Is the numbers, just it's a realistic number to expect, 12% of the numbers that you don't want to see.
It's not that we didn't want to see them, it's that they were making unstable estimates to base the cost report on those. We can't do that.
And again, we didn't go back and try to verify any of this, so it could be that someone filled out the survey wrong and included incorrect information.
Yeah, and in some cases we did.
Yeah.
We
I
did
mean,
go
some of
back.
them-
Can I follow up? And so, I mean, and this is more for understanding, you know, the data side of things, whatever. I'll give an example of our community is that I can guarantee you that you call 911. I will send a minimum of 2 paramedics and 3 other providers to every single call. Okay, with that, and this is for me understanding how you analyze the data, is that taken into account in your cost analysis of the personnel going to that scene if I accurately reported my costs to you?
It would be, but it will be part of an overarching statewide average that looks at our included sample, and ultimately the results of cost recovery were based on these rate recommendations. 70% of transports, they're either profiting or breaking even. But there is 30% where we're looking at licensed EMS units that are still incurring costs that's in excess of these rates. And that's because we're calculating a statewide rate. We're not calculating an individual recommendation
So
for each.
That's a policy decision we had made in our community supports that. So if I assume that, let's assume that either I was with Fred and we were in one of the 12, or we're on the higher side of this, and we are now going to take a cost cut in our commercial insurance. If this passes and goes through, is that something that, I mean, that's almost like punishing our taxpayers for supporting this?
I would say it differently. I would say the condition on the bottom bullet, was going to in the future be better met, that if you're inherently cost ineffective because you're sending excess resources to it in the cost constrained market,
But
then you would migrate towards the median and be more.
I guess we would have to have a separate discussion about what's considered excess resources.
If other municipalities are in the distribution of all the other costs, or the other municipalities are right in the center, and then there's 3 or 4 that are way out to the right, that's what it's a signal of.
I think it's a bigger problem than that, because I think you have to look at what we have for personnel available. I have more personnel available in the southern part of the state than anybody up in the northern part. There's no way that they even have that on their fire department, much less being able to respond to one call. So I think there's a lot of variability in here, and that's what I think a lot of this is with us, at least from the fire EMS side, are struggling with, is trying to take what we have and be able to fit it to what your data is showing. And so it's going to be a significant change. And I'm not sure how that's
These
going
are
to
the
play out.
data that were submitted by EMS units.
Don't disagree at all. I totally get the data. I used to be a chemical engineer like 25 years ago, so I totally understand and respect that. I'm just trying to understand how this data is going to be able to fit into what we provide
and the service and how we provide those services to our kids.
Hey, guys, we're about 3:00. I just want to be respectful of Megan's time. I do see a few more questions in the room. Are you okay to?
I'm good. I'll stick around.
Take a few more
Yeah, and I'm
questions?
happy to chat with folks
Just
after as well.
4:00 in the room. Well, so we'll try to take the last couple questions in the room, but Megan, if you've got her, she's traveling from out of state, so just be respectful of her time if she's gotta hit the road and head home.
I'm driving. I'm good.
Okay. And then I'll see her in the office.
Going to the French question. Do you have a breakdown of the response, the percentage that were fire-based EMS, third service or private EMS?
I don't. We just have the breakdown of the sample that we reviewed compared to the statewide sample. And so but I don't have it at the response level.
Anything specific on those 12 that were declared outliers? Any breakdown on those?
No.
You still have a question? Go ahead.
Yeah, so you can't reveal the 12 to us, but the 12 were eliminated because they were higher in cost, correct?
Outliers.
So with that though, we know how many calls those 12 made up. Is it possible now to say that they actually, because they could be major cities or communities, they might make up 60% of all EMS calls in the state? So that would skew your entire report. Because it wouldn't be the data that's really going on. Do you understand, like, I get those 12 services will cost more, but if those 12 services did 70,000 calls combined, and the state only does 100,000.
I can answer that. I can confirm that they are not significant volume relative to the overall statewide transport activity. And there was a pretty clear correlation between the number of transports provided and the cost incurred to provide the transport. So the larger providers tended to be more efficient operations, where those that got screened out as outliers tended to do much less overall response activity, which I think generally is consistent with what I would expect to see.
That means that they've gone like, because that's what I was wondering, like an Alton, for example, that's split down the middle by a lake. And so their costs are gonna be a lot higher just because their geography or some of the really small towns up north. Is it possible that that's skewed, or did you double check for, the super regional geographic diversity remain the same, even after excluding 12 of the 85?
So even after excluding 12 of the 85, the regional diversity, I think we've got our map in here of this is all the respondents, so it's not representative of those that were included. But we did receive a significant volume of responses representing all areas within the state, and we had a geographic distribution that we felt was appropriate relative to the sample or the larger universe. Yeah.
Everybody that's shaded in participated in the survey?
Yep, we got data from at least one licensed EMS unit in each, serving each of these counties.
You articulated everything perfectly. If you didn't have the answer, I would say well done today, so thank you.
Thank you.
Thank you, sir.
I appreciate the appreciation, and I appreciate all of you. I think that you're asking some really good questions that should be asked.
The gray areas, there's 4 services within that gray area that are about to close. And this will severely impact their ability to maintain and keep their service in check. The larger agencies, not so much, but multiple towns that are gray, that are at the root of some of these issues, are not even representative in this cost center. That's all this.
We did a study before we started this study. We did another study before this. And then in that study, we found out that the entire, what we tried to find out is who is using the ambulance services. And I think I've mentioned this in the committee before. 8.7% of the ambulance service calls, I guess, or I guess I would call it calls, are for the insured market that we're trying to address. That's all. The rest of it is Medicare, Medicaid, and a bunch of other little tiny things.
But unfortunately, what the insurers do will have massive impact on that. When you say it's 0.01%, the frustrating thing, and you know, I've been in the committee meetings, I show up to all of them. And what frustrates me is initially, you know, to get what the ask was on some of these bills, it equated to $7 a month per insured person. And instead of putting that expense onto the insurance company, it's put millions of dollars on the taxpayer. And unfortunately, in your committee, that's what you have the way. And I know I seriously respect you for coming here and asking your questions, and also the representatives on the phone, and also, you know, your group for doing it. I mean, we need help. This system is in crisis. And so I think that as everyone, and I know most of the room, and they care so much about this because there's a lot on the line. And it's always comes down to when trucks or services don't have the money to respond, who is Russian roulette? And nobody wants to play that game. And, you know, there's some interesting information and, you know, some darts being thrown, but I do think that this is underfunding. I do think that this has significant impact that's going to impact communities statewide. And the insurance companies have not shown, let's just say, their best foot forward. They want to do what's right. It's all about profit for them. And for us, it's about survival and the ability to get the truck out the door. We're having salads, not steaks. And that was said to me coming through the door by someone who has more years of experience in the state than I do. But your committee has to just seriously weigh the impact of these numbers.
And we have. And the problem we have is if we were to try and raise the insurance rates to the point where it covers everything that everybody wants, there would be no more insured people left.
Nobody
We would
expects
all
that.
lose that.
Nobody expects
My
that.
feeling is we need 4 more bills.
I agree.
This bill is only one step. You need 4 more. We can't handle some of the other things that we're talking about. We have to get to Medicare, we have to get to Medicaid, and we have to get to the ERISA plans. And they are not under our purview. We need more bills. Otherwise, we can't solve the
I
problem.
totally agree with you. I just would like to see that when this gets discussed, and the 2 meetings ago when I walked in, your chairman said, we've been here before, we're all educated on this, and don't, if it's not new information, I'm not interested in hearing it. And so for us, unfortunately, that tells us,
That's
not
it.
you.
That's a purely emotional response to something we don't have any control over. Please, we would be glad to help you write the other bills that are necessary, but we are in a small bubble. That is all that we are.
Okay, I'm gonna-
We need more.
Let's leave this for the legislature. We can. I think there's enough committee hearings still left on the docket that we can argue this one out there. But are there any other questions for Megan relative to the cost study that we can address while we're in the room? And please, if you have questions and follow up to this as you're kind of gone back and you're taking things in from today's presentation, if you have questions, please, I think you all should have at least my email from sending the invitation out. Don't hesitate to send those my way and we'll circulate those internally and with Megan and see if we can get an answer as you've gone back to think about everything. So if there's no other questions, last call. Okay, thank you very much.
Thank you, everyone.